Welcome to our webinar session for June 2nd today. We have two really informative speakers. We're looking forward to hearing what they have to share with us, but as usual, I'd like to interrupt us for just a second with some orienting information. This is still our homepage for the COVID webinar series, and this has, we update it as much as we can as we go along, but I want to draw your attention to two features, please, today. And one, of course, we still have this sign up for our mailing list. As we start to wind down the webinar series, we'd like you to sign up so we can tell you if we restart. So we do have two more sessions planned at this point, and we are gathering information to see how we might continue. If you sign up, we'll certainly be happy to let you know when and how we continue with the series. Also on our website, we do have a feedback survey that we would like to ask you all to complete for us. This will let us know how you have enjoyed the session so far. We're also asking if you have any opinions or suggestions for future sessions. I'll be flashing the URL that goes directly to the survey in the chat box in just a couple of moments, and we would be very grateful if you would take a few minutes to please complete this survey for us. On the website, just as a reminder, we do put the recordings on YouTube. We link them to the website so you can find those. And for those speakers who have given us their slide presentations, we link that to the homepage as well. If you would care to register some questions for today's speakers, you'll find the Q&A box at the bottom of your Zoom screen. Please put your question there. We'll look for them, and hopefully we'll have time to forward a couple of questions to our speakers at the end of the session today. Finally, I'm pleased to introduce those who will be teaching us today. We have Professor Munther Dali from MIT. Professor Dali leads researchers in the general area of decision-making uncertainty, with particular attention to the economic value of data, finite data decision-making, and his group has been doing some really progressive work dealing with the COVID-19 pandemic in order to inform policymakers. He'll be our first speaker. Our second speaker is a UCSB faculty member, Susan Castles, in the Department of Geography, and also affiliated with the Broome Center for Demography. Professor Castles is an expert in infectious disease epidemiology. As both an epidemiologist and a demographer, she studies the social and behavioral determinants of viral transmission, including mobility factors and the application of mathematical models to examine the importance of various behavioral risk factors. And today, Professor Castles will examine different potential responses to COVID-19 on the basis of social and environmental determinants of health, health impacts beyond infection with the virus, and emerging inequalities in the US in relation to the pandemic. So that's more time than I should have taken, but I'm very happy that our speakers are with us today. I'll turn it over to Professor Dali to tell us about his findings. Thank you again.
Thank you. I'll get started. Thank you, everybody, for this wonderful invitation. It gives me an opportunity to tell you a little bit about some of the work that is going on at MIT. A group called Isolate, it's IDSS COVID-19 collaboration. This is the outcome of a collaboration of different people. Hold on, let me see why this is not. Yeah, faculty, student, postdoc, staff, and so forth. I mean, we come together daily at 5 p.m. We started 12 weeks ago, and we had a very steep learning curve trying to figure out a lot of stuff about the pandemic and things related to it. So I'm reporting the outcome of a lot of different work. And if you're interested in more detail, you can go to the website and it lays out sort of these posts that discuss some details about where this stuff comes from. Okay, so I'll talk a little bit today about intervention and economic impact. I don't want to bore you with a lot of details about the coronavirus. It's a pretty potent virus, 6 million positive cases so far, and about 370,000 deaths. Somehow the large incubation period for this virus is causing a lot of problems in terms of contagion, We have issues with testing. We're still not up to scale in terms of PCR testing, but it's actually ramping up. Hopefully, we have a lot more. Antibody testing is still questionable in terms of reliability. It seems like the reaction to the virus changes from different demographics, different age groups, and so forth. A lot of the stuff, the questions being asked is how do we manage this this contagion? Obviously, you know, if we had a vaccine or a cure, that would be the best way to go about it. But in the absence of the two, how do we think about managing and understanding this particular contagion? So I'm going to start by first talking about, so I'll talk about different things. The first thing I'll talk about is the data. So a lot of the problems we had dealing with this problem is that the data is noisy, and conclusions based on the data has been somewhat difficult. But do we abandon that, or is there something interesting in that data that we can take advantage of? So I'm going to give you two scenarios over here that are interesting to analyze. The one on the right over here describes you know, a typical exponential growth of contagion. This is typically what's predicted by SIR models. So if you look at this curve on the right, which has just got frozen for some reason, now there you go. It shows an exponential growth for a certain period of time and another exponential growth for another period of time due to maybe potentially some intervention. So it's just a fictional picture. While the picture on the left shows a sub-exponential growth. So there's an intervention where actually the growth has started tapering off and went down. And a lot of the questions that we were asking earlier on and still up until today, whether or not we are in the regime of flattening and are we going down, or is just noise and we're going to go up again. So now typically the way we will, and of course all the cases that we look at could be either severe, mild, or asymptomatic. That's always the case in this virus. It seems like asymptomatic cases were a larger percentage of what's going on. Now, in general, the way we would do this in statistics is that we would actually do randomized testing. So if we have random testing, we get 5 or 10% testing, then we get data sets that look like this over here, and we will be able to predict what we're looking for. Sub-exponential means that if we look at the log of nt plus 1 divided by nt, it looks like a minus bt, right? So b here is a positive quantity, which kind of contributes to the sub-exponential or the flattening of this particular curve. If b is equal to 0, then we are in this regime where we have only exponential growth. So can we actually predict whether b is 0 or not equal to 0 from data? Well, randomization helps. If we have random experiments, then we can typically say a lot from a statistical perspective, construct hypothesis testing, and come up with the answer. Okay, but that's not what we had. What we had is something completely different. Namely, the data that was collected was commonly from people that had severe reaction to the virus or to a virus. So you went to the hospital because you were sick for a reason, and then you got tested for the coronavirus, and then reporting was happening. So a lot of people were discussing the fact that we're missing a lot of the data because we're not testing the asymptomatic or the mild cases. We have a lot less information about the total number of people, and that's definitely true. However, so what we're measuring is only from the severe cases in all of these scenarios. So one actually, in order to use this data, we make some sort of a simplifying assumption that actually is relatively accurate, and that is to think about the severe cases are a constant fraction of the total number of cases of infection. This can be stratified by, say, age groups or by demographics and so forth, smokers, non-smokers, people with diabetes and so forth. But in principle, the cases that we're measuring are a constant fraction. So if we're actually looking at the question of flattening the curve or sub-exponential growth, we can still do that with the data that we have, because that what we're looking for is insensitive to the total number. It is only dependent on the trend of that value. And so we've been using the data from the reported kind of cases, which typically are severe, to draw a lot of the conclusions. And it turns out that it's actually quite helpful. So the question from a statistical point of view, did we flatten the curve or not, is a hypothesis test of looking at the log n over m. By the way, these are the types of models that are predicted by SIR models, but I'm looking at them essentially as a non-parametric sort of non-mechanistic models, right? So if you do statistical tests, you're asking the question, is B zero, that's a null hypothesis, or B strictly positive, that's the alternative hypothesis. And we did this analysis to a lot of the data in the United States and also in India, and we got curves like this. This is back in mid-April. I didn't update the curves. But in mid-April, for example, if you look at Massachusetts, we were in the red. We actually were not yet flattened. You can see that over here. While, for example, if you look at a state like Maine, we were, it was already flattened and it was a sub-exponential. Massachusetts was still an exponential growth at that time. In fact, in April 17th, we did this sort of analysis to see if we can predict the apex. And the apex is the peak value of this particular curve. And the way you would do this is to try to find the time when the B value becomes strictly positive. When B is positive, that's when you have the exponential drop and the flattening of the curve. And we, for example, noticed that California actually by certain areas in California actually has flattened. But for example, in Massachusetts, they were not. So the Middlesex County, for example, was predicted, according to our analysis, to flatten around the middle of May. This is analysis done around the middle of April. And in fact, we do see right now in the, and so this is the actual prediction of B with the confidence interval. So confidence intervals are fairly high. They're large values, and the uncertainty quantification is an important component of analyzing this data. But we discovered that, you know, it's about 35 days where the apex will occur, and in fact, it did occur around that time. So this analysis says something about the fact that it has certain predictive capability. We were able to use this also to explain the multi-peaks. New York exhibited one peak and another peak. This has actually been perplexing for modelers because typically SIR models gives you a one hump, not two humps. Well, but I mean, that's not actually difficult to imagine that, you know, if you had a stochastic network model representing SIR as a network SIR, then it is possible to have a peak occurring because of one community and then a transmission occurring to another community where then you see a different peak. And so we actually used either superposition of SIR models shifted by time, or actually just purely kind of Gaussian mixture models. And we were able to predict these humps also as they were coming to the system. So kind of indicating that the contagion is not happening in a sort of a mean field, but rather contagion is happening within communities, which I think is really important. Happens within a community, a transmission occurs, and it occurs within this community, and then tracking this, it turns out that mixture Gaussians actually give you a fairly nice way of predicting this sort of types of behavior in any case. So the data was not all that bad at the end of the day. It was predictive in some ways. And so we were also in parallel asking the question about intervention. Intervention is a really important question because we are trying to understand whether what we've done matters, you know? So what would have happened if a policy was implemented instead of the policy that we did, you know? In particular, here we're going to focus on mobility as a way of measuring the shelter in place or the lockdown. In fact, we're using retail mobility as a feature or as a metric for measuring mobility. And so what we need is to understand, can we actually answer the counterfactual question? What if we did this? What if we added more lockdown? Could we actually result in a better infection rates or whatever, right? The data that we use for the mobility analysis, and you can see that on our website, is actually death data, because turned out to be fairly accurate, not too accurate, but accurate enough, you know, because a lot of stuff was attributed to this. Not sometimes people die from corona, but they were going to die from other reasons, and so the way it's attributed has errors, but nevertheless, it's fairly reasonable data sets around the world, and we use this data from all around the world. Doing synthetic, there's no control group here. So in order to answer counterfactual questions, typically you need a control group, but we have no control group. So we have to create what's called synthetic control groups. And there's a full description of how synthetic control groups can be created directly from data, essentially by regressing on certain parts of the data sets. I don't have enough time to describe that to you, but certainly that's on our website in complete generality. And here are some interesting results that we had. So we took data from all around the world, and we tried to figure out whether we can predict the different levels of mobility. So here you're seeing data on the green is essentially very severe mobility restriction. Orange is about 10 to 40% mobility restriction, and then blue is about 10% reduction. So initially, the United States was in the blue over here. The solid blue line is the actual number of deaths by the number of with the number of days over here. The blue line is the actual curve for the United States. The analysis shows if the United States implemented the 10% to 40% or above 40%, this would have been the expected growth of death, substantial reduction, actually, if we applied more severe conditions early on. Also, we are able to use the same analysis to predict without knowing what happened. And so so that the implementation of a 10% also was predicted fairly accurately using our method as a validation of this particular synthetic control group. Similarly, in the United Kingdom, very similar story to the United States. Very high death rates, could have done a lot better if it used sort of more severe mobility lockdown. Turkey is another country where they've actually implemented 10 to the 40% in retail mobility. And the green line shows that they could have done better if they implemented 40% or more, and they would have done worse if they implemented the 10% like the United States. Again, we were able to predict their own data fairly accurately. Sweden always kind of creates a little bit of a problem in that it's never clear exactly what they implemented. They're close to our 40%, but they actually do a little bit better than what appears to be their implementation. But by and large, it's fairly good. It's not as accurate as the other countries. Finally, I would say India implemented a very severe lockdown, and you can see here the matching with the green curve. The blue and the orange are the expected, what we would have expected had they not implemented such severe lockdowns. In fact, if India did what the United States have done, their number of deaths would have increased by a factor of 9, which would have been a substantial number of people given the situation there. So this is very interesting to see that, in fact, you can actually isolate the effect of the intervention using entirely data-driven activity without having a model, and certainly not having a control group. You can predict these particular outcomes or the counterfactual outcomes. So itching to open, I think that right now we're in a situation where everybody wants, and I'll talk a little bit about the economic impact. Economically, it seems that there are strong motivations to move back to some form of opening the world, the country in particular, the United States. But without, as I said, vaccination and without cure, it's not going to be possible without active control. This is for my control theory colleagues listening to this talk. I think active control is the right way to do this. And the question, do we need very accurate models, or can this be done with qualitative models, in the sense that what control theory is good at is understanding the direction in which you take control, but not necessarily the exact values, and you can actually be quite robust in making good recommendations. I would say the key variables for controlling an epidemic is testing, distancing, and quarantining. Testing and quarantining are key components. The idea is that you test and you remove people who are infected, you contact trace, and you remove everybody else that is being in contact and has been infected. If you're able to remove people from the system, then I think you have a way of controlling the infection. And then the second thing is distancing. This is controlling the R0, which I'll talk a little bit about that in a second. So we've been developing, of course, both analytical and simulation models using SIR network type models I won't bore you with the details of these things, but essentially these are large networks with where they're connected, where each node represents um, a discrete state about a particular infected person or a community. You can aggregate however you want to. But if you think about this as UCSB, for example, then each node can be a person at the university. It carries a discrete state of being susceptible, infected, hospitalized, ICU, recovered, whatever. And also it could describe their movement within campus. So for example, you could carry on that particular node a continuous state that describes where they are at any given time. This obviously is something that can be measured using some of the apps that are being suggested by Google and others, and MIT is developing our own app for tracking everybody's movement. And the point is, this model now, just in terms of, and then we have a probability of, you have to specify your neighbors and who you're in contact with, and what's the probability that you infect somebody if you come in contact with them. We do the analysis using probabilistic graphical models, but then in actual design, what you have to do is to track these values precisely, and so one has to build these models from the actual data. But a model like this can allow you to ask a lot of interesting sort of what if questions. I mean, there's a lot of interesting what if questions. What if, for example, we decided to quarantine elderly people or people with pre-existing conditions? How is the infection? How does the infection grow? So the red line is doing nothing, and the blue line is the situation we're in today, which is social distancing. So if you didn't social distance, but quarantine the elderly and the people with pre-existing conditions, so clearly separate them entirely from anyone who's infected, you get quite a bit of benefit, but not as well as separating everybody, clearly. So, so this kind of shows you a little bit the trade-off that is ongoing over here. But for example, if you look at hospitalization with the same what if question, now all of a sudden the numbers of hospitalization are approaching each other, which tells you that hospitalization has been, towards people with pre-existing condition or older in terms of age. And then at the end, if you look at the death data, the models predict that actually death data would have been better if you just quarantined entirely the people with pre-existing conditions or older, and then the actual situation we were in. So that's a what if scenario. As you think about economic impact and so forth, this can be quite helpful to understand what's happening. I wanted to say before we go into a lot of details that the R naught analysis, and we spend a lot of time trying to understand what R naught is. So if the common thing is the number of people that one person infects during the duration of their infection, right? And so R naught for this particular virus has been quoted somewhere between 3 to 5, 3 to 6, But I wanted to say that as we were doing a lot of analysis to open up MIT, R naught can be a lot more, can have a much wider range. So if you decompose R naught to what it is, it's the probability of infecting a contact times the number of people that you come across, times the duration of the infection period. You can see, for example, that if you're in an enclosed space with a lot of people sitting in there, R naught could be as large as 50. And this is exactly what happened in places like Biogen or the synagogue meetings and so forth, is that, you're talking about an enclosed space with a lot of people interacting at a close distance. R naught is not 3 to 6, it's a lot larger. And so by just taking R naught as a uniform quantity doesn't necessarily describe what's going on campus, for example. And so we've been cognizant to kind of break that into the pieces that we have. Another what if question that we ask is, how is R naught versus immunity change, right? So there's a conversation about, sort of building herd immunity. And does herd immunity actually allow you to have more interaction between people? And of course, the answer to that is fairly yes. Of course, if R naught, as the system theorist among the group, for R naught is less than 1, you know that the system is stable. And so you're in this black region over here. Any level of immunity is good. But for example, if you are R naught equals to 2 or 3, this is the unstable region. But as the herd immunity increases, you can be stabilized. And you see this particular curve. This is all done by simulation. You see this curve that looks like you know, 1 minus 1 over x kind of a thing. And so you wonder if there is actually a theorem that tells you what that boundary looks like. And it turns out that, yes, there is a very simple interpretation of all of this stuff. So turning this into, I've got a few minutes left, like 5 minutes. So turning this into a control problem, and I'll come back and tell you about the idea that we've been thinking about is we need to sort of do testing, contact tracing, and quarantining. So the idea of control is use the information that you have so far to rank the probability of infection, test the people with highest probability of infection, remove them, and contact trace to remove everybody else from the system. So how do you actually rank people in terms of their infection, depending on their connectivity and the tracking of who they come across? We use ideas of centrality or page rank, you know, sort of kind of the person that is connected to the people that are connected to many people. Also hotspots of where people seem to interact, then you kind of come around in areas that then move to different areas that are also congested. And then also talking about immunity testing. So for coming back, you know, to try to solve the problem, at least at MIT, we're talking about substantial amount of testing. So first, test and contact tracing is one, and the other one is distancing. So, you know, what is the level in which we can allow people to come close to each other? How do we control R naught, you know? And there the idea is coming in terms of creating cohorts of communities, which a lot of states are saying, you know, you can interact with people with 10 people around you, but no more than 10, and you gotta know everything about these people that are around you. So can we mimic that situation in a university? Can the students exist within a pod of 10 to 20 students that are taking classes together, living together, and have minimal interaction with communities around them that is not distant? That is, you know, these people are interacting normally, but then when they interact with other people, they're keeping the 6 feet separation and so forth, right? So we're trying to come up with this proposal and understand it. So I will tell you about, quite a bit quickly about rules of thumbs for testing to understand what goes on. And the idea here is focus on this side of the picture for a second. You have a bunch of susceptible people. They're getting infected at a rate of R naught divided by TR. TR is the length of time a person is infected. So this is the probability of infecting one person. They get infected by that rate. And what we're trying to say is, if this quantity is high, then the infection grows exponentially. Can we stabilize it? Well, we want to stabilize it by testing and removing people from the system. So how fast do you need to test in order to actually stabilize that system? But that turns out to be sort of an MM1Q or a birth-death process, where the increase is happening with probability R naught over TR, and then the removal of from the system is happening with the roughly probability 1 over TF, which is the fraction of people, 1 over the probability of testing, which is the fraction of people that you're testing. TF is the fraction of people that are being tested and removed. If this product is less than 1, you actually create a stable Q, and the system is stable. So to get some numbers going, if R naught was equal to 2 and TR is 20, this is roughly 0.1. And so that means that you can test roughly about 10% of the population and be stable. So that kind of gives you rough estimates, very gross sort of estimates of how you test people. And immunity just factors that in, you know, it just kind of makes that better by multiplying by 1 minus the level of immunity. So we've been developing a lot of these simple rules for testing. I don't have enough time to tell you about them, but basically they all are consistent with the analysis from these graphs. I guess I have a lot of slides over here. 2 quick slides, I would say. So those rules are now being implemented as our baseline for how we're going to test on campus. How do we test students? So the number of tests that we can do per day dictate how many students can be on campus, because the rates have to remain stable. This graph shows the comparison between doing randomized testing, for example, which is Yeah, so randomized testing or no testing and versus centrality test. So if you don't test, the infection grows very rapidly. But if you do randomized testing, you see, for example, you're getting this purple line. However, if you do centrality testing, so you test the people that are most dangerous or most infectious, you see that this is the curve that you get over here. So there's a lot of gain that you can get out of that system. Very quickly, I want to say we have a story about masks, but I don't have time to tell you. Sorry about this thing. Just one thing about the economic impact, I wanted to say that, and I will conclude, the idea of lockdown was very interesting because what it did, it sort of had a lot of health benefits. So this is a graph of lockdown versus fatality. As we increased the lockdown, we initially, of course, reduced the number of dead people, and we initially did very well in flattening the curve. But then what is happening is that at some point in time, fatalities are going to increase due to other factors, namely economic situation where there's unemployment, despair, lack of food, and starvation around the world. We start expecting that the fatalities actually increase. And so while in fact we're trying to save lives by lockdown, economics can kick in, and that's why, in a way, a solution that has more active control in terms of testing and distancing sort of does the trades off these two in the best possible way. So that's my conclusion. I'm just saying we've been looking at a lot of aspects of this problem. I invite you to visit our website that I gave up front. It has all the details of these things. I didn't discuss masks, but we have a full discussion of how masks are effective and how they reduce the space and interaction between different people. And if you have any questions, I'm happy to answer after the talk. Sorry, I went over. I appreciate your attention. Thank you. And I transition directly to Susan, who will give her talk, and then we'll answer questions.
Okay, thank you so much. Let me share my screen. Okay, so actually the end of that talk was a really nice going into what I plan to talk about, which I wanted to start off, this is better for the populations, because as we were just talking about, increasing lockdown saves people's lives, of course, but then other social and economic factors kick in to cause poor health for others. And often those consequences are felt unequally across the population. So this question of which is the best response for the health of populations, of course, I can't answer this question right now. Modeling could help answer this question, but the answer will depend on people's perspective, when the question is asked, where the question is asked. But I want to talk through two key concepts or theories in order to kind of think deeper about this question. One is, which many of you, I imagine, are familiar with, the social determinants of health. And the second is I'm going to use the fundamental cause theory to look at long-standing health inequalities and kind of explaining why we see inequalities in COVID-19 deaths currently, and how we can then respond. Okay, so let's get started. So social and environmental determinants of health, that will help us think through what are the drivers of health outcomes, but also health behaviors. And the second, we'll be thinking of social conditions as a fundamental cause of disease. Why do we see these persistent health disparities? Okay, and one more kind of introductory slide. I want to define health, right? Health is a dynamic entity that basically is present until death. But one way I like to think of it, which lends itself to thinking through social determinants of health and health from a broader lens, is that health is a continuing property. And it can be measured by an individual's ability to rally to a bunch of insults, whether these insults are, chemical, physical, infectious, like a SARS-CoV-2, psychological or social. So this definition really focuses on resilience, and it helps us understand why, after being exposed to a bunch of insults over time, such as racism, someone's resilience is lower. So that puts them at a higher risk for poor health. Okay, and then the social determinants of health, I'll talk more about that in a minute, but these are the conditions in which people are born. Yeah?
We're not seeing your slides. Do you want to share them again?
Oh, I'm sorry. The whole time you weren't seeing them?
Okay, now we are. Thank you.
Okay, gosh, I'm sorry. Okay, so here we are. Thank you. Can you see them now?
Yeah.
Yes.
Okay, so the social determinants of health, right, so I don't think you missed much in terms of the slides, but okay, the social determinants of health are the conditions in which people, live, grow, work, and play, and these conditions shape their health. So we'll talk more about that in a minute. Okay, so what are the health effects of COVID-19, or the health impacts? Of course, there are the direct effects. So if somebody gets infected with SARS-CoV-2, they may be asymptomatic, or they may get sick. There may be long-term complications or scarring, and of course, death from COVID-19. But there are two other things that we should think about. The second is indirect effects. And these are causes of death that may not be treated in the same way or treated at all because of the coronavirus epidemic. And under normal circumstances, it would not cause death in most cases. And this is an estimate from the New York Times just a couple days ago that showed excess deaths. About 70% of excess deaths right now are directly due to coronavirus, but another 15 are from heart disease and diabetes, and others are from flu and respiratory diseases and other causes. So we are seeing impacts from indirect effects of COVID-19. And then the last one is the one I want to talk about most today, are these downstream effects. So social, emotional, economic, political, or other disruptions that are either intentional because of lockdown or social distancing measures, or unintentional because of the coronavirus. And these can lead to both delayed or magnified or recurring poor health. And one of the key issues here is there's heterogeneity in exposure to these downstream effects, and that we need to think very carefully about. Okay, so the social determinants of health, basically individual-based risk factors for health must be contextualized. We must think about why people come to be exposed to risk or protective environments, and what are those social conditions under which these risk factors are related to disease. So anywhere ranging from economic stability to neighborhood exposures, education, food, but also social conditions of neighborhoods. And here are just 4 specific examples. So, we're here at UCSB, we're talking about online instruction. Online instruction can be very unequal in terms of access and quality, of course, and this can have long-term health impacts on educational attainment, labor market performance, and as we know, that could lead, we see a severe socioeconomic status gradient in health, where people who are more poor have worse health across the spectrum of health and disease. In utero, infant, and early childhood exposure to viral infections, say SARS-CoV-2, or nutritional deprivation because people don't have money to feed their family, that can also have long-term and significant impacts on health, cognitive development, labor market attainment, etc. Parental unemployment and hardships in the household, that could lead to challenges in mental health, union stability, divorce, domestic violence. So that has an example of unintended consequences. And lastly, community relations and children's peer contact. We're not quite sure yet what long-term effects this change in social interactions and ability for children to play may have on their health. Okay, so the next few slides, I have just some specific examples. So this is a recent paper from Lancet Global Health, and they propose that the direct impact of COVID-19 on children's and adolescent mortality may be limited, but the indirect effect could be very significant, up to 1.2 million deaths for children under 5 globally in just 6 months, which is a staggering number. Here's the paper if you want to take a look at their assumptions and their models. But the causes of these deaths would be things like strained healthcare systems, household income loss, which could lead to food insecurity, disruptions to care seeking and preventive interventions like vaccine, therefore leading to an increase in vaccine preventable disease. Just for a little history, globally, we've made significant strides in under 5 mortality in the last 20 years, significant strides, and it would be really sad to see some of those benefits slide. Mental health, so this is another paper. This hasn't been reviewed yet. This is a preprint. But among the data, I think this is from Connecticut, non-healthcare workers, at least half of them reported high levels of anxiety and loneliness. And this varied by some personal attributes like gender, marriage, and knowledge of COVID-19. But in my work and work on health disparities for a long time, we see that social connectivity is a very strong protector of health. People who are socially connected and have better health, and of course, anxiety and mental health disorders can be very challenging. Stress is another one. This is from the Kaiser Family Foundation that say 4 in 10 worry and stress from coronavirus has a negative impact on their mental health. And this is very true for college students too. There's been some studies on college students and their stress. 1 in 5, I think, have supported significant anxiety of college students. And unfortunately, we've also seen an increase in suicide and suicide attempts here locally in Santa Barbara County based on some data from Cottage. So these both have very significant direct effects on health, but also can have long-term negative impacts as well. And I think 1 or 2 more examples, or 2 more. Food security, 1 in 4 say they have skipped a meal or visited a food bank or received SNAP benefits since February. So food security also has a significant, is a driver of poor health, not just if you're hungry, but then people who are hungry or children who skip meals are less able to concentrate and learn. And of course, this has long-term impacts on their health as well. And then lastly, adverse childhood experiences. This is, such a huge concept. I'm sure I can't do it justice in the next slide or 2, but I think it's really important when we think about coronavirus and thinking about the health effects from a broader temporal and spatial scale, we really need to think about ACEs. So ACEs are potentially traumatic events that occur to children aged 0 to 17. We measure them through, so it's usually a score from 1 to 10. It has to do with whether the child experiences different types of abuse or trauma, but it also has to do with the climate of the family. So whether a parent is incarcerated, marriage stability, drug use and mental health in the parents. And each of these scores is associated with significant chronic health problems as an adult. So this kind of pyramid shows what happens often if a child experiences is a dose response curve too. So the more adverse childhood experiences, the unfortunately the worse health that they can expect as an adult, but it's through disrupted neurodevelopment, disruptive cognitive and social impairment, which also leads to adoption of high-risk behaviors. So it's not just direct, but indirect through behaviors as well, disease, disability, social problems, and often early death. So the point here is that the health impacts from COVID-19 and the responses to COVID-19 may have health impacts that aren't fully revealed for generations. And just as an aside, ACEs can increase health behaviors like lack of physical activity, increases of smoking, alcoholism, and substance abuse. Children who experience the adverse health effect, ACEs, can expect a 4 to 12-fold increase in alcoholism and drug abuse, suicidality, increase in smoking. 40 to 60% increase in some other health outcomes as well. Okay, so that's kind of the first part, is I just wanted to think through, you know, someone can get infected with SARS-CoV-2, develop COVID-19, have long-term effects of that. There could be indirect effects of, you know, reduced health-seeking behavior or diseases that would usually be treated that aren't. But there's this whole other elephant in the room that I think we really need to think about when we make decisions about moving forward, strategically responding to coronavirus. Okay, and then the other main point I wanted to say is that these exposures and the consequences of exposures are not felt equally. There's significant inequalities of health that have been persistent and strong across diseases, ranging from heart disease, obesity, diabetes, to infectious diseases like HIV, syphilis, gonorrhea. We've seen these forever, and those of us who have worked on health inequalities for years, unfortunately, we're not surprised to see these health inequities arise with the coronavirus as well. Okay, so just a few slides on data of health inequities with the coronavirus. So these are data from the New York City that show disparities in COVID-19 outcomes by non-Hispanic, white, Latinx, and Black individuals. We see, you know, 50 to 60% higher confirmed cases of Black individuals compared to white, even higher odds ratios of hospitalizations. And for both Latinx and Black, given that they've been infected with coronavirus, there's twice as likely that they would die from the virus compared to white. And then there's another data source that I wanted to share, covidtracking.com. This is a COVID racial data tracker. Has some really great data by state. Simply here we're showing that the top 20 counties with the highest infection rates aren't necessarily counties with high proportions of people of color. Most of them have majority white populations, but the story changes when you look at the death rates. So the counties with the 20th highest death rates, 4 of the 5 are majority Black or African American. So that tells you right there that there's definitely an inequality. Okay, so in order to think through this, I wanted to introduce this concept called the fundamental causes theory. And I think thinking through why we see health disparities by race and socioeconomic status with this fundamental causes theory just makes it's less surprising that we see these disparities. So a fundamental cause of health inequities has 4 components in order to be considered a fundamental cause. First, the causes influence multiple disease outcomes. So whatever this upstream cause is of poor health or health inequities, it causes health inequities in multiple different outcomes. So for race and ethnicity and health outcomes, we see disparities not just in COVID-19, but in many other diseases, like I mentioned before. Second, the cause affects disease outcomes through multiple risk factors. Third, the cause involves access to resources that can either be protective, assist in avoiding health risks, or to minimize the sequelae of disease once it occurs. So if there's a fundamental cause that restricts this access or limits this access, then that has these poor health outcomes at the end. And lastly, and actually this is one of the most important ones, the association between a fundamental cause and the health outcome can be reproduced over time, even if there's interventions to these intervening mechanisms. So one idea is thinking about racism and obesity or diabetes. We see a very large racial inequity of obesity. And one intervention could be, well, let's build bike paths or ensure, food deserts aren't there, access to healthy foods. There will be, if racism really is a fundamental cause, then it will find a way, it's not a good way of saying it, but it will lead to these inequities in the health outcome through a different path. So in order to actually improve the health of populations and reduce disparities, targeting these intervening mechanisms won't work. You need to go all the way upstream. Okay, so socioeconomic status and racism are both then fundamental causes of disease and health inequities. Okay, so let's talk about racism. How does racism cause increased risk of COVID-19 exposure or heightened mortality rates based on exposure? Well, this is of course a much bigger issue than I can talk about in the next 2 minutes. I mean, this should be something that we as a society talk about for the next 10 years. But racism causes these, it's basically the biological effects of these shared experiences and social trauma, structural violence, generational trauma. And so there's this great resource called Dear Pandemic that some colleagues of mine from grad school are running. And I'm borrowing some of these results from Dr. Bronner, who I put the reference up here on Twitter. And she was talking about kind of 3 main ways that racism can lead to increased risk of exposure and poor outcomes based on exposure. The first one is that either discrimination, mistreatment, or trauma can lead to this overactivation of the stress response. And I'm not talking about just, well, it could be both consistent microaggressions based on someone's race or ethnicity to major trauma like what we've been listening to over the last week with George Floyd and all of these other horrendous current events right now. So, you know, stress and release of cortisol is a normal response, but if this stress response gets triggered over and over and over again, it leads to inflammation, which leads to kind of a weathering or a breaking down of someone's ability, like this definition of health I said before, to fight insults. This has been one of the pathways in which racism can get under the skin and cause heightened risk of heart disease and diabetes, for example. Another pathway is segregation, population density, and essential jobs. This leads to direct exposure for racial and ethnic minorities in the US. There's been, you know, years of structural racism like redlining, or in Minneapolis, building highways that deliberately kind of separate communities of color with other communities, and then certain communities of color are less invested in, and there's housing projects and higher population density. The types of people who work in essential jobs are often lower income and people of color. So this leads to direct exposures, higher exposures than others. And lastly, racism has been associated with access and quality of healthcare. So for many, many people of color in the last couple months, there's been stories that they just have not been treated the same when it comes to showing up at a hospital with a fever or you know, symptoms of COVID-19, which leads to a delayed response, which leads to a poor health outcome of disease. Okay, a couple more slides. So these disparities in health have existed forever in both race and socioeconomic status, and it's concerning that this current coronavirus might be widening these existing health disparities. So it's not just the direct exposure, like I mentioned before, but it's these other kind of social determinants of health. So this is another graph from Kaiser Family Foundation that looks at the share of people who have been skipping a meal based on coronavirus. So the lighter blue are the people who have already been doing this before, and then the darker blue are the families who are now skipping meals because of the coronavirus. And we see the highest risk populations are low income people and African American and Hispanic individuals in the US. Okay, so what do we do then if we now appreciate that these fundamental causes are leading to health inequities in coronavirus, but many other things? What do we do? Well, we can still talk about intervening mechanisms like increasing testing and connection and workplace policies, but I really think we need to address racism as a fundamental cause of disease. So both at the interpersonal, individual levels, you have conversations with your family, but also at the institutional level. So at UCSB, you know, this can be more baked into our educational policies and social policies. And at a structural level, we need to, you know, insist that our society becomes more equitable, reinvest in communities without gentrification, but uplifting communities, talking about healthcare reform. And all of these things need to be done in partnership with existing community organizations. Okay, so my takeaway from this talk, just my thoughts, if I could try to package them a little bit, is I just want people, if they're trying to think about strategic responses to the ongoing COVID-19 pandemic, and one of the key outcomes is the health of populations, we need to think about this from a broader spatial and temporal view, over space and time. So we need to account not just for the direct and significant effects of coronavirus and the indirect effects, but these downstream health effects using the social determinants of health framework. We need to assess how heterogeneous health effects are happening now, but how they will appear later. You know, if you're thinking about the ACEs framework, how somebody who is living in an unsafe household now, or a student who had to go back home and live with their family when it's unsafe to do so, that might have health effects later in the future. And then lastly, we need to think about health disparities. Personally, I feel like it would be a failure if we increase the average overall health of our population, but we don't do anything to address disparities. So we need to keep health equity at the center of our conversations. Okay, thank you so much. You're on mute, Ambush.
All right. Thank you both for a wonderful talk. And there is a question which has been asked. So this is to Munter. So there is a question about how do you measure mobility and how did you add as a variable in your model? Munter, are you there?
I'm there. I don't know, for some reason my video, oh, hold on.
Okay, please answer. That's a question that has been posed to you.
I got it, yes, okay. So yeah, we used Google data on mobility, which has been made almost public. I mean, we were able to get that, and we stratified mobility towards, we call it retail mobility, so mobility into retail stores and out. You know, so that's how we looked at that, and we classified that, or we segmented it into 3 different categories. So we defined a metric based on mobility. Yeah.
Thank you. So there is a question that I would like to ask you, Susan, in a minute that I have. So you are saying that the problems that we are facing are very grave and we cannot solve them. So that may give some of us saying, okay, this is beyond what we can do locally. This has to be done at the scale of the entire country over tens of years. How do you respond to that? So,
I guess I was not hoping that that was the message that came across. Maybe I need to do a better job of being more optimistic with my presentations. No, I feel like there are important intervening mechanisms that we can do now, but we all can work now, locally and globally, on addressing the upstream causes, the fundamental causes. So I don't think it's grave. I just think we need to be cognizant of where to direct our efforts. You know, housing policy is healthcare policy. You know, economic policy can be healthcare policy. We just need to kind of change our scale of thinking, and then we can get to work now. We don't have to throw our hands up.
Thank you. I think we are at the end of the webinar. Thank you both for a wonderful talk. Thank you so much. Thanks.
Welcome.
Bye.
Bye-bye.